Thank you for your introduction. Hello, and Shin Chao, distinguished colleagues and esteemed attendees. It is an honor to stand before you today at this esteemed International Medical Congress. This topic will be presented by myself, Shin Okazaki, and my colleague, Dr. Takeshi Inoue. We talk about two cutting-edge topics on epilepsy. No COI. Our program is showing this slide. We are from Osaka City, Japan. Osaka City has a population of 2.7 million. Our hospital is a tertiary medical institution located in the center of Osaka City and near Osaka Castle and also Universal Studio Japan. This is inside of our hospital. We have about 1,400 epilepsy outpatients. Let's get down to business. Neurologists face major challenges in epilepsy practice. There is uncontrolled seizures, even when treated by specialists, has been told the same number of more than 10, 20, 30 years. We present diagnosis and treatment from onset of epilepsy in Japan. First, families notice seizures and decide to go clinic. Second, if the physician suspects the child has epilepsy, we refer to the secondary care center or tertiary care center. At secondary care center, in addition to medical examination, EEG or blood tests are performed to diagnose epilepsy and start medication. If seizures are uncontrolled, physicians refer to tertiary care center. In epilepsy cases, showing accurate medical information, including videos, between family and physicians is an important factor, but it's not always easy. Our first cutting edge is smartphone application, Nanakara. Nanakara makes it easy to accurately record seizures and share medical information with physicians. Accurate information allows for accurate medication and vice versa. Seizures always come suddenly. Nanakara can record the seizure anytime, anywhere, immediately, and easily. Nanakara has spread in Japan, as is now downloaded by about 1 in 4 families of children with intractable epilepsy. As families use Nanakara, Nanakara for Doctor has also spread in Japan, and now nearly half of pediatric epileptologists have issued account. Now I show a short movies of epilepsy examination of our hospital. The doctor used Nanakara in this. Nanakara can use by tablet. Since tertiary care center is a few, we are developing Nanakara to create telemedicine tool for those who live far away and cannot commute. We will show using a telemedicine tool, Nanomedi. Due to time constraints, we were only able to discuss some of these tools. These tools are medically supervised by us and developed and operated by Knock on the Door Inc. in Japan and Code Brit Inc. in Vietnam. Please visit the sponsors booths in this Congress. We are looking to collaborate with doctors in Asia. With Nanakar as a hub, physicians will be able to collaborate more smoothly, and children with intractable epilepsy may be referred to tertiary care center more quickly. In Japan, epileptic surgery is a big part of the role of tertiary care center. Dr. Inoue will explain about surgery from now.
Okay, from here, I'd like to talk about the current status of epilepsy surgery in the hospital. In 2015, here we started a comprehensive epilepsy center, and the number of patients of epilepsy surgery has increased. And corpse callosotomy is a mostly performed and followed by lesionectomy. And we already performed the subdural electro with the 30 patients. And from this year, I started stereo EEG. Of course, seizure medication is started with the anti-seizure medication. And in some patients, ACTA therapy or ketogenic diet may be used in combination. However, more than 30% of the patient seizures are very intractable. And guideline in Japan about epilepsy, we have to consider the epilepsy surgery when seizure persists with 2 or more appropriate anti-seizure medication or persists for more than 1 year. And it is also added in pediatric patients, the indication should be considered promptly with regard to 1 year to prevent the regression of psychomotor developments. So consideration of the appropriate timing of epilepsy surgery is essential for optimal treatment. And recently, time to epilepsy surgery getting shorter and shorter in our hospital. However, some patient takes more than several years, but we have to make an effort to fasten the epilepsy surgery. And we have to, for example, we have to, now we would like to present as soon as possible case and hemispherotomy for hemimegalencephaly with intractable seizure and hemiparesis. This patient is manifested hemispheric abnormal region, and we have to consider the hemispherotomy as soon as possible. So this, in this patient, we perform the epilepsy surgery on a crash emergency basis. And the other one is corpse callosotomy for drug attack and intractable epileptic spasms. This is a patient instructional video created by our department. We found myself in trouble when we express the corpse callosotomy. It's very difficult. Anatomy of the corpse callosum and the function, and how the procedure of the corpse callosum. So we made this video like this. Yeah, this is an overview of the epilepsy surgery, and here is corpse callosotomy and vagus nerve stimulation is performed for the palliative treatment. And how about lesionectomy? If the patient manifested a clear lesion like this, and there is not inconsistent with the other functional image, we choose lesionectomy like here, and then the patient became seizure-free. However, as shown here, patient whose seizure onset zone is unclear from multimodal investigation, we choose the video EEG monitoring using subdural grid electrode. And during video EEG monitoring, we analyze where seizure arises and how does it spread. And before the second operation, we have to perform the electrical cortical stimulation for functional mapping. And this is a representative cases. So I'd like to show the video. This patient presented with fencing posturing, right arm extension, left arm flexion, and ended with the hip elevation like this. Maybe this seizure similarity is common in supplemental motor area seizure. And after confirming the relationship between seizure semiology and multimodal investigation, we decided to the resected area like this and led to seizure-free. And next one is praxis-induced SMA seizure. The pathology was FCD type 2A. This patient seizures are provoked by counting beat, like this. Okay, and in this patient also we place a Greek electrode interhemispheric region of the left medial area and decided to the resection area like this. And how about the complication of the epilepsy surgery? Like this patient, both patients didn't show the hemiparesis and finger motor impairment, like this. Okay. Yeah, and another representative case is epileptic spasm. And epileptic spasm is a very challenging seizure in Japan. And more than 30 patients came to our hospital per year. He manifested like this movement. Okay. Yeah. So let's move on the representative cases. She manifested ACTH and more than 5 anti-seizure medication intractable ES. And this EEG is showing bipolar montage, and blue line indicates the left hemisphere, and right hemisphere indicates red lines indicate the right hemisphere. And it's difficult to recognize a clear, precise epileptogenic zone. And what's the next choice? When in Japan, patient is medically intractable ES, we, after evaluation of the scalp video EEG monitoring or brain MRI, and difficult to delineate which side of brain is a core epileptogenic zone. In these patients, we choose a corpus callosotomy. And after corpus callosotomy, her seizure limited to the right side of the brain body. And how about the EEG? EEG also limited to the left hemisphere, these blue line, like this. And then, what's the next choice? Yeah. After CC, if the EEG and semiology limited to the hemispheric hemisphere, we choose the next additional resection therapy. In this patient, we perform the subtotal hemispherotomy. So in this patient, maybe callosal modulation, this thick red line is maybe higher than the, we delineate the abnormal region restricted to the left hemisphere. So next, we choose additional resection surgery and then lead to seizure free. So like this frontal disconnection, like this, and the posterior disconnection, preserving the primary motor area. Then ES free for 5 years. Of course, the patient became half blindness and had a finger fine motor impairment. However, we believe that epilepsy surgery was considering even with these sacrifices. But we need to discuss the pros and cons of epilepsy surgery with parents and their patient and their parents. Yes, here is the last slide. We can easily grasp the seizure records and the effect of treatment in clinic by using an app such as Nanakara. Moreover, we are establishing and promoting a telemedicine system using personal health records such as Nanamedi. We'd like to link telemedicine between primary and secondary care center and our center. And also, we believe this type of telemedicine can be used across country and would like to collaborate with other Asian countries in the future. For example, starting with a joint conference. So please feel free to contact the Code Complete at the exhibition booth or directly to us. Thank you for your attention.